Good afternoon, everyone. Yes, my name is Jim Burt. I'm Executive Director for Programs at the National Academy for Social Prescribing. National Academy was set up about 3 years ago to promote and champion social prescribing across the UK and in fact globally. We have an international global alliance, which we might touch on during the course of this call. And we work very closely alongside the NHS, and our primary objective is to support people with unmet social needs with social solutions, which is sort of what we're going to explore over the course of the next 15 minutes or so. It's a bit of a whistle-stop tour of social prescribing, so I do apologise if perhaps we're moving through this quite quickly, but I thought it's useful to set out the strategic context and the sort of framework for social prescribing. So that's what I'll cover in the talk. I'm just going to upload my slides, if that's okay. Can I just check that everyone can see that? Yeah. Yep, okay. So these are the 4 elements that I thought we could cover off today: the strategic drivers and challenges around social prescribing, the social prescribing system itself, the infrastructure, the essential infrastructure that makes up social prescribing, and that's where we might get into some elements of how faith-based communities might support that infrastructure. And then if we've got time, I wouldn't mind just looping back into talking a little bit about loneliness and social isolation, because I think that's one area where faith-based communities can make a really quite profound contribution. Well, I'd like to start with just probably setting the scene around what I think are the 3 strategic drivers for social prescribing. One is that in the UK, we have a rapidly changing demographic. So we have increasing life expectancy, massive increase in older people. So the number of people over the age of 50 will be increasing by 50% by 2030. We have the fastest rate of aging in 100 years. And we have a rapid increase in complex long-term needs. So by 2035, 2/3 of people will be living with multiple health conditions, and 1/3 of these people will have mental health illnesses, which is dementia, depression, etc. The second big driver is financial sustainability of the NHS. So in 2000, the health spend of the NHS represented 27% of the day-to-day public service spending. By 2024, it's forecast to be 44%, a massive increase. And the final one is health prevention. So currently we spend around about 1/5 of our lives in poor health, and the poorer you are, the greater proportion of your life you spend in poor health. And 40% of NHS costs are estimated to go on treating preventable conditions such as cardiovascular disease, where it's costing us around about £20 billion a year. So those are the drivers. And here are what I think are the 3 strategic challenges. The first is health needs are changing for obvious reasons that we've just covered. So we're changing from managing infectious diseases to managing degenerative diseases and mental ill health. It's the first shift. Second one is that we need to pivot from treatment to prevention. We need to move upstream in helping the whole population to stay healthy and for longer. And the social determinants are leading to increasing health inequalities. So clinical care contributes about 20% to health outcomes. 80% of health outcomes are attributable to social determinants. So social factors are driving both health outcomes and health inequality. So tackling these challenges requires a social response, and that's where social prescribing comes in. So what is the social prescribing system? I think it's made up of 3 components, and they're differentiated by the way in which we connect people to social activities and services and information. At the core of the system is the red area, is where people require specialist support. These are people with identified health needs, social care needs, and they get specialised support from services such as the social prescribing link workers or other allied health professionals. The next zone or domain are where people are connecting to activities and services through community support. It could be through friends, it could be through neighbours, through volunteers, or through receiving information from targeted targeted information campaigns. But they need support. The third way of connecting people is where people actually don't need that support. They don't need external support in order to connect with those activities in their community. They have the agency to do that themselves. They have the ability to do that themselves. They've been able to understand that they need perhaps to undertake more social activities, more physical activities. They are able to find out those activities themselves and are able to make their way to those activities. So they don't require any external support. The area today that I'm really going to focus on is that middle domain. So if you look at the link worker program, which the NHS has set up, it established it about 2-3 years ago with the intent of appointing 4,500 link workers across the country. The forecast that we've made would be that when all of those 4,500 link workers are appointed, and we're about just a little over halfway through that appointment process, they will support around about 4.5 million appointments a year. So to put that in context, there are 300 million appointments to GP surgeries each year. There are about 150, just over 150 million appointments to GPs specifically. And if you were to think that 20% of that 150 million are likely to be people that are in GP surgeries for socially determined requirements. That is, they have a social requirement, not a clinical requirement. So that you've got about 30 million of those people. The link worker program will support about 4.5 million of those appointments. It's not trivial, it's about 15%. It's critically important. These are people with specific needs, but it represents only a small fraction of the total demand and pressures on the system. So if you were to look at that whole system, if that is going to be a well-functioning social prescribing system, I think it's made up of 3 components. We need to have activities that we can offer people. We need to have places in which those activities are delivered and supported. And we have to have people who are connecting the users of those activities with the activities themselves. If we go into a little bit more detail about that, so the activities are self-explanatory. You know, they cover everything from those activities that you would expect to see in the natural environment sector, gardening, walking, the physical activity sector, cycling, dancing. The arts and culture sector takes you into choirs, art, into craft, music, etc. And then the final sector would be financial support, financial advice, and we work very closely with the Money and Pension Service in providing that sort of service. So those are the sorts of activities that you are trying to connect people to. Those activities are quite fragmented. So one of the challenges is to bring those activities into spaces, into places where there are multiple activities brought together. They're complementary, they're supporting people's health and well-being, and that takes you into the conversation around community hubs, social hubs, they're called different things, talking benches where people can meet, faith centers can be community hubs, libraries, museums, leisure centers, village halls, and open spaces, green spaces, urban green spaces, for example. Those are all the places in which those activities can be brought together and offered to people. And then there are the people that do the connection. And those are the link workers that I described at the very core of the social prescribing system. There are what often is referred to as buddies. These are people that are out in that community-based social prescribing area where they have some expertise around a particular thematic area. They could be nature buddies, they could be heritage buddies, they could be sports buddies. So they have experience and expertise in a particular area, and they connect people with an unmet social need with those activities. But they could also be friends and family, and they could also be delivered online and on through telephone conversations and other signposting services. So those are the three components: the activities themselves, the places in which they're delivered, and the people that are connecting those users of those services to the activities themselves. So I just wanted to say a little bit more about the connectors, and I wanted to say a bit more about the hubs, because I think those are areas that the faith-based community might have a particular contribution to play. So in terms of connectors, these are citizens who can signpost people to access points into the social prescribing system. They are not formal volunteers. They may receive some short-term training, but they use their own knowledge of the local community, and they signpost people to appropriate services and activities. And examples of those, which are already out there in multiple communities across the country, could be anybody from police officers to taxi drivers to hairdressers and cafe staff. There's a group down in London which is run out of a barber's shop, for example. But there are also faith leaders, staff or members of faith communities or faith outreach programs. These are all examples of connectors. And then, as I said earlier, there are topic-based connectors, nature buddies, heritage connectors. And those set of connectors are being promoted and supported through multiple organisations such as Natural England, Historic England, Sports England, etc. So those are the connectors, critically important, and they sit alongside and complement the work that the social prescribing link workers undertake. The next bit I just want to talk a little bit more detail on are the community hubs. So these can be both physical and digital places, and they are places where activities can be carried out. They often have link workers co-located in them, and they signpost people again to events and activities. And they can host directories of services within those hubs, and they can service the access points for people entering into the system. They can be hubs that, such as a library or a museum that accommodates a large number of people, or they literally can be a park bench. And I've given the example there of a sort of a scout hut in one community, and there could be an open space, a parkland, or a gallery in another community. The critical component to a community hub, though, is that it's co-designed. Its placement and function of these hubs need to meet local community needs. So they look different in different parts of the country. They're structured differently. They're different places. But the critical bit is that the community feels that they have some involvement in the shaping of the services that those hubs deliver. And as I say, there's a list of examples there that range from libraries through the green spaces. So in terms of NASP's ambition in this space, I think we have basically half a dozen objectives for what we think would be a thriving community. First of all, that every place has groups and services and projects available for the public to access. And these groups and services feel supported. That's a key component. That every place has access to professionals who can support them around what matters to them. What's important in all of these conversations is what matters to the individual. that social prescribing link workers feel themselves to be supported and are able to offer their best service to people who need them the most. That every place has easily identifiable access points where people can find out about groups and services, they can find out about information in ways that suits them the best. Again, working with and through the community and what it requires. That people can get involved in lighter touch ways, and we've talked about, nature buddies and heritage buddies, to be able to spread the message about something they care about that will enable people to understand where those activities and services are and how they can easily access them. And that people have opportunities to get involved in their community themselves through volunteering. Those are the components of what we think is making up a thriving community. Lastly, I just wanted to touch a little bit on the scale of social isolation and loneliness. So all of this, I suspect you're very much aware of, but just to quickly whip through the scale of loneliness and social isolation. 1 in 20 adults in England, 1 in almost 10 children in England are reporting often feeling lonely. That young people are 5 times more likely to experience chronic loneliness than those over the age of 65. And then there's a series of high-risk areas, high-risk social groups, including women, disabled people, people on lower incomes, and people with low well-being and high anxiety. Then there's the sort of impact that loneliness and social isolation have on people's health outcomes. And these, again, include increased risk of early mortality, poorer cardiovascular outcome, worse mental health outcomes, increased risk of depression, particularly amongst young children and young people, increased risk of dementia. So significant health impacts. The evidence, however, suggests that social prescribing can offer a really effective way of reducing loneliness, and the consequences of that are reductions in demands on GP time, on A&E visits, on admissions and social care visits. And the reason I guess I'm mentioning this is because I think that the faith-based community has an amazing opportunity to address specifically loneliness and social isolation, but also because DHSC, Department for Health and Social Care, is about to complete its mental health strategy, of which social prescribing is a key component that runs through that, and loneliness and social isolation is at the heart of that strategy. So it means that faith-based communities have an immediate point of traction within that government strategy. So that is a bit of a fly through social prescribing, both in terms of the drivers and the challenges, but also the system that it sits within, and some of the opportunities, I think, around loneliness and social isolation. Thank you very much for the opportunity, I think, for coming along and talking to you. Very happy to take questions.
So let's open it up. We'd love to hear your reflections, thoughts, ideas, and questions. So if you've got anything, put a virtual hand up, a physical hand up, or type it into the chat. And whilst you're doing that, let me just clarify with Jim. You mentioned citizens can signpost to information access points. Can you just give us a bit more on that? What do those information access points look like? Where are they? And perhaps an example.
Yeah, sure. Right. I mean, access points could be digital. It could be an online directory, for example. It could be a telephone service. So some primary care networks or GP practices, let's call them that, offer telephone services where people can ring in and get advice about where they should go in terms of certain services and activities. So it could be digital, it could be telephone. or it could be a physical place that people go to. And those places vary. They could be wrapped into a hub, or they could be something like I'll call it a talking bench. I guess I'm trying to find something at the other end of the spectrum. Literally a place that people can go to and talk to other people who have some expertise in terms of being able to signpost them, to have some expertise and knowledge about signposting them to activities in their local area. So there are multiple ways in terms of access points.
Thank you. Sam in Harrogate, you've got your hand up.
Hi, thank you. Thanks, Jim. That was great talk, and it really helped to put a lot of language and structure around things that I think churches are doing an awful lot of already. And what I'm wondering is, do you have any advice on how we can access funding from healthcare commissioners? Because obviously with faith communities doing this more and more, it's a massive cost saving to the NHS, but you know, we have to then fund that, you know, a lot of staffing and things like that to make it happen. So have you got any advice on that? And then the second question related to that is there any best practice or advice you have with regards to connecting well with GP practices in our local area, so that what we're doing isn't in isolation, but connected in with what local healthcare providers are observing and seeing and needing, and also so they know where to signpost people to?
Okay, so thank you, Sam. Great question. Two great questions. The funding one is a very common question, and my advice is probably not what you're expecting, which is you could seek support via the NHS, but I think that's quite a tricky road to go down. I think I'd be looking more widely. I'd be looking at the sorts of funding that is coming out of both philanthropic endeavours, funding that's coming out of central government, such as the DCMS work that they're doing around Know Your Neighbourhood, funding that's coming through the Arts Council, through Sports England, through Natural England. There's a multitude of funding opportunities to build the infrastructure that I've described, either the sort of places that you could repurpose to shift them to become social or community hubs, albeit I think in this space, in the faith-based communities, they are already pretty much servicing that purpose. Or the creation of, or enlargement of, or improvement to activities and services. So my sense is that I'd be looking beyond the health system for support around social prescribing in terms of funding. The second bit about connection into the system. Again, I think there's two dimensions to this. There's the sort of connection into the health system itself, and we can certainly sort of support you on that journey. We have both a regional and hyper-local a program called Thriving Communities that is specifically set up to connect people to the health system, but also to connect them across the service providers within their locality. And then we have an equivalent national program called Accelerating Innovation Program, largely designed for national bodies that are trying to do exactly what you've described. Well, they're actually a little bit more than what you've described. They're trying to often connect into the health system. They're trying to amplify and grow the scale and quality of the services and activities and the provision that they make. Often they have a fantastic delivery model in one part of the country, but they want to spread it across the whole country. So they want to lift and spread. And they want to enrich their offer by creating new innovative partnerships with new partners to be able to create greater impact with the services and activities that they're developing. we enable all three of those things to happen at the national level through Accelerating Innovation and at the local level through Thriving Communities program. Both of those programs come together and deliver bi-monthly webinars. And you could go onto the NASP website. You'll not only see all of the programs that have the webinars that have been delivered to this point, which straddle everything from what is social prescribing all the way through to working with, what is good practice with respect to volunteering, what are the opportunities with respect to housing associations, and everything in between. And in fact, tomorrow I was going to be on an NHS social prescribing link work call, again talking about the contribution that faith-based communities can make into social prescribing. And though that is part of a webinar series that the NHS runs. So those are ways of connecting into the system. And also you would find on the NASP website a whole raft of evidence that underpins the evidence that it shows the evidence of impact associated either with different sectors, arts and culture, natural environment, physical activity, or with respect to particular audiences, target audiences. So I would encourage you to look for that evidence. And there's also lots of advice about and good practice about in relation to social prescribing. That all sits on that website and is freely available. And I would strongly encourage you to take a look. I hope that's gone some way, Sam, to
yes, thank you very much.
supporting it.
Thanks, Jim. I think you've covered Karen's question there. So Pete in Basingstoke.
So my question is about working with existing social subscribers. So we've already been connecting and coordinating some of the wellbeing work across Tadley, across Basingstoke, and know that there are a number of social subscribers already working within the GP practices. What would be your recommendation of how we can link what you're talking about with the church initiatives, particularly in terms of what you were saying about what they're doing isn't enough to be able to meet all the needs?
So I guess I would strongly encourage you to go and have conversations with those social prescribing link workers around what they are doing to support that wider system. There are great examples of where that's working really, really well, where they've moved out from the link worker sort of model, if you like, into the wider community-based social prescribing, which I'd be very happy to give you links to. But I think that would be the conversation I'd be having with them, because if they want to try and reduce, the pressure on the NHS and give people a better and more sustained solution to their non-clinical needs, then they're going to have to find a way of building within their community that infrastructure that I've described that's going to support the middle domain of that system. That will help people to remain healthy and well, and therefore not ever enter the health system. And that ultimately is the prize. So that's the conversation I'd be having, and I'd be encouraging everyone on this call to be having those conversations with their local social prescribing link worker team about what system they are helping to set up and establish within their local communities.
That's great. Thanks, Jim.
Thank you. Lloyd, would you come in and ask your question?
Yeah, hi everyone. Not so much a question as just some comments, if I may.
Yeah.
I'm very happy to receive any comments Jim wants to make. So I'm the chief executive of a charity called Saltbox in Stoke-on-Trent. Amongst a range of caring services we provide is one called CareLink, which is telephone befriending for elderly vulnerable people. So we have a staff of 5, about 300 elderly people we work with, and about 40, 50 volunteers who make about 15,000 phone calls a year. We get some funding through the NHS, through what used to be CCGs, clinical commissioning groups. We get a bit of funding through adult social care from the local authority. I think my observation is this: certainly, social prescribing should be giving lots of the voluntary sector, including faith, greater opportunities to connect. But the challenge is making those connections locally. I think local connections with both the NHS, which has just undergone its major restructure, as many of you will know. So we now have Integrated Care System and ICS, which has replaced CCGs, and will be another three-letter acronym in due course, I'm sure. But they're trying to get their act together, and so trying to engage with the NHS locally can be a real challenge. Absolutely. They're just trying to keep the show on the road, and if they've already got connections with the local voluntary sector, that's great. But anyone new coming along, whether that's wider voluntary sector or faith, it's sometimes really tricky to make those connections if they're not already there. Similarly with adult social care, what we're discovering, as we will all know, is that the government will cut even more money out of local government. Adult social care will come under more pressure. It should mean there's greater opportunities for the voluntary and faith sector, because they're going to be looking for, let's be honest, cheaper, more effective alternatives than paying social workers to do the work. My observation is that if you're not already involved in conversations locally, then people need to be positioning themselves, either one, to engage more fully with their local voluntary sector forum. I've been chairing our local voluntary sector forum in Stoke-on-Trent for a number of years. And whilst you get some Christians involved with it, obvious examples would be the YMCA, for example. There are very few local faith connectors who engage with that voluntary sector forum. Often it's that voluntary sector forum which has the way into social prescribing at a local regional level. So my encouragement would be to go and knock on the door of, if you've got a CVS these days, Council Voluntary Services, it's another three-letter acronym, then to knock on its door, because there will be local forums where you need to engage. Going cold into adult social care through the local authority, or cold into trying to connect with health through the new ICSs or place-based partnerships, PBPs, another three-letter acronym, is a real challenge. So I wouldn't want to put anyone off, but as you suspect, if you're not already aware, I think it's a real minefield out there to try and get your voice heard, to try and establish yourself. And so my own personal advice from a local perspective is just to go and start having coffee with people, if you're not already, with those voluntary sector connectors, forums, trying to find out how your NHS or local authority is trying to work with faith communities. But I wouldn't underestimate, sadly, the challenge. Whilst the opportunities are definitely there, if those connections aren't already being made, then it will be a challenge. And I wish I could be more encouraging, but I think the opportunities are there. But if you're starting afresh, those coffee conversations early on to get your face known, your name known, your project known are really important. And again, sincere apologies if that sounds negative, or sincere apologies if I'm teaching my granny to suck eggs, and you all know that anyway, and you're doing it in spades. So apologies.
Oh, that's great, Lloyd. We are so grateful for the huge amount of experience you've got, and thank you for sharing. I just noticed Jonathan's comment there. It's our responsibility to make it much easier for the statutory sector to connect with the faith sector. And I think I'd want to echo that in terms of the place and value of unity movements, church networks working together, but actually together we can have a coordinated, joined up conversation with the ICS or civic authorities. So if you're interested to talk about that and explore that, please do get in touch with myself or any of the Gather Movement team, and we can help you think through that. Any other questions that people want to ask?
Mike, can I just give
I submitted one to in the chat to our speaker. I don't know if he's caught up with it or if it's relevant.
Remind me of that, Jonathan. What was your point?
I just said, very simply, it was this. As I listen the description we have is about how we rediscover community. The proactive suggestions work for me, but there is a challenge too. In business and in policy, much that's designed mitigates against community. I'll give you one example that is possibly non-controversial rather than a controversial one. So across the UK, supermarkets and others are moving to digitalizing checkout counters, so there will be no one there to talk to when you leave. In Thailand, that's illegal for two reasons. One, because it undermines community. Two, because putting people in supermarkets creates employment. So I'm really interested to know how we counter both policy and practice from statutory and also business that mitigates against community.
Yeah, that's a great question. Thank you.
Do you want me to respond?
Please do, Jim. Yeah.
So I guess my observation is that, I mean, you're absolutely right, Jonathan. I mean, we are looking at communities that have got quite depleted connectivity, and that depletion has taken place over 15, 20 years. And those are often the communities that have the greatest health needs, greatest health inequalities. So we are trying to rebuild a system. My sense is that central government recognises the task, but is struggling to necessarily bring policies into effect, and struggles to do that in a way that makes it feel like there's change on the ground. So, but I think there is a strong desire to make those changes. How quickly they'll be made, I don't know. If you look, so I just park. I mean, there's a raft of policy sort of areas that we could touch on, but the DCMS policy around mental health, I think, will touch on this quite extensively through the prism of social isolation and loneliness. Just circling back to the previous comments that Lloyd was making, which I again would completely agree with in terms of some of the challenges, and therefore being careful about where you invest your time and energy and effort. Two observations really. One is, through the Thriving Communities program, we have teams in each of the 7 NHS regions. Those teams are made up of multiple agencies. So we have representatives embedded in that from Arts Council, Natural England, Sports England, Historic England, etc. They are working at that hyperlocal level with some of the organisations that Lloyd has described that stand over the local voluntary sector. And so if you wanted to, I'd be very happy to give you the contact names for the leads in each of those 7 regions, and you could be working with and through them and their networks to make the sort of connections. It might just accelerate some of the connections that Lloyd was describing. And the second bit around funding is that we've been working with National Lottery Community Fund to establish what I would describe as a shared investment vehicle. So this is a vehicle that would sit, an investment fund that would sit alongside each of the ICSs. It would be funding activities and services aligned to the health needs within that ICS, and it would be open to investment from public and private and philanthropic sources, with the intention of building that to a fund of about £1 million per ICS as a starting point. Now, it's not going to be the silver bullet that you're probably looking for in terms of funding, but it shows a direction of travel, at least in relation to a way of bringing funding for the provision of services and activities right alongside the ICSs on a sustained basis, because that's the other bit, is that we need not only funding, we need sustained funding, so that local, small, voluntary organisations are not getting pulses of money that are coming through that just mean that there's a sort of a burst and bust type, situation going up and down in terms of the growth of the sector. So those are three responses, I think, to both Jonathan and Lloyd's observations and challenges.
Thank you, Jim. That's great. We're Peter, go ahead.
Yeah, Jim, coming back to your presentation, you were talking about the number of people who are attending doctor's surgeries and who it would really be good to feed into the community. And what we've seen a challenge there in terms of referrals because of the confidentiality issues. So if a doctor or someone in the surgery just says, go along to this event or that, people are too shy to be able to do it. And what they really need is somebody to come alongside them and take them. But that cuts into confidentiality because professionals aren't allowed to tell the volunteers about that individual. Have you come across that anywhere else? And is there a way around it?
It does manifest itself a bit. I have heard that observation before. I mean, it should not be an issue. I mean, the whole intention of the social prescribing link worker is they sit down with the individual and to understand their personal circumstances in order to create a sustained solution to their unmet social needs, whatever those social needs may be, and that they should also be supporting them in accessing those services and activities. And by that, I mean not only giving them a palette of opportunities, a link to their interests and their needs, but also going along with those individuals, introducing them to those activities, potentially staying with them for the first one or two of those sessions until they feel comfortable in those activities, and then and only then should they be withdrawing. And I mean withdrawing as in an active participation in the activity itself. So I think that's one mechanism, is through the social prescribing link worker, but that's also a function of those wider connectors. They are also there to provide that guidance and support for individuals who are feeling that they don't have the agency, they don't have the confidence, they don't have the knowledge of what exists in their community, and they don't know where it's being delivered, and they don't necessarily have the wherewithal physically in order to be able to get access to those activities. So all of those are some of the roles that a connector can support with. And then the hubs are trying to bring some of those services into a co-located space and provide much easier access to those services so that you can go along to one place and you can potentially do anything from, an art and cultural type activity through to a physical activity, and at the same time potentially see a social prescribing link worker. So an example of that would be, and I'm sure you have many examples of it, but the example I would bring up would be something like a library. So we've worked with all the libraries across Luton, for example, who are now delivering a whole range of services, as well as having link workers embedded within and working alongside the library services themselves. That's the direction of travel, I think, Peter, we need to go in.